I will try and approach this in a manner slightly different from Akash. I'll not go too much into the details of so much that Akash has covered. I'm surprised at how much he's managed to cover in that time that he has. I'll just talk about the cases and try and demonstrate how we approach them when they present to us. So my first case is a 54-year-old male who was previously healthy. He presented with a history of high-grade fever and joint pains and myalgia for 3 days. He consulted a family physician who had prescribed him 5 drugs, 5 different types of tablets. So that cocktail included NSAIDs, a paracetamol on top of that, PPIs, multivitamins, and a vitamin D. It's like one big cocktail. So in spite of this, he continued to have the symptoms. And so he was given 2 injections. We don't have the details of those injections. They were just IM injections. No labs were done. So after this, he noticed some pedal edema. He revisited his family physician, even though he didn't have any oliguria. At that point, he was found to have hypertension. His BP was recorded as 150/90. Some investigations done at that point showed a serum creatinine of 2.3 and a urine routine that was active. There was proteinuria 3+, blood, which was 2+ on dipstick, WBCs were 10 to 50, and RBCs were 20 to 30. I'm guessing they thought UTI and they prescribed levofloxacin at 500 milligrams BD. Now, this itself is a much higher dose than what is required for a simple UTI or an uncomplicated UTI. But this is what was prescribed, and the patient continued to feel unwell. Okay. Yeah, all right. So at this point, the patient panicked and took a second opinion from another doctor. May have been an Ayush doctor, we're not really sure. And that doctor prescribed 2 doses of Dexa. So he's 3 weeks into his illness now from when he first started, and he's now feeling better after the Dexa injections, obviously. And therefore, he was lost to follow-up. 6 weeks later, he comes to us with persistent headache. And the BP now is 160/90, and he was referred to me. So labs were repeated. At this point, the creatinine is now down to 1.6, but the urine is still active. There is proteinuria, there is blood with both RBCs and WBCs. So what are my differential diagnosis at this point? We know that he's received a cocktail of drugs prior to this. And so always there's a possibility of a drug-related AKI, which will most probably be an acute interstitial nephritis. There is also the possibility, given that he started off with proteinuria and an active urinary sediment with RBCs and WBCs. So there's a possibility of a glomerular disease with AKI. And there was always a possibility of a urinary tract infection, but that is not higher up on our differential diagnosis. So coming to the drug-related AKI, the most common drugs, although it was classically started off with classically described with an NSAID, most common drugs are now proton pump inhibitors. And then you have the NSAIDs and the ACE inhibitors, ARBs, and the aminoglycosides. The risk for AKI with drug-induced, drug-related AKI is not dose-dependent. There are even cases where patients have received just the 1 dose and ended up with an AKI. So that's something that when you prescribe these drugs, you should be aware of. And like Akash said, it is not necessary to prescribe these drugs without an end in sight. So the prescription has to be rational in terms of the number of days you want to prescribe it for, and given the specific disease that you're looking at, how long and at what dosage. And that should be constantly revised and revisited. If you're looking at the glomerular diseases, given the fact that this patient has proteinuria and an active urinary sediment in the background of fever and myalgia that he started off with, we would think of an infection-related glomerulonephritis. But classically, this used to be a post-streptococcal GN, but over the last 2 decades, the epidemiology has shifted considerably, and now we know that a whole host of infections, including some viral infections, and also COVID, has been shown to cause an infection-related GN. And so it has to be in our differential diagnosis, even if the classic symptoms of a sore throat or a skin rash are absent in a particular patient. So the pathophysiology here is quite simple. There is complement deposition within the kidney, which may or may not be there, along with immunoglobulins, and that triggers an inflammatory response, resulting in what we see as an infection-related glomerular nephritis. If this patient started off as a UTI with an AKI, our aim should be to try and distinguish between a lower urinary tract symptom and upper urinary tract symptom. So your classic lower urinary tract symptoms will present with cystitis features. So lower abdominal pain, urgency, frequency, dysuria, sometimes pyuria. And because this is a localized infection, you don't get the systemic fever and sepsis-like features. On the other hand, if you're dealing with an upper urinary tract symptoms, pyelonephritis, you will have loin pain, you will have fever, and those should be differentiated early on to aid the treatment, because obviously the treatment for pyelonephritis is going to be much more intense than a simple UTI. And especially in elderly males like our patient, it should be in the back of our mind to evaluate for obstructions, which could be prostate related or any other. So with this patient was further investigated, the urine culture did not show any growth. There was no eosinophils on the urine in spite of checking. The USG was normal in size with the maintained CMD. When we did a complement levels, it was low. So we biopsied this patient, and the biopsy showed an infection-related GN with a background of some acute interstitial nephritis and tubular injury. So this patient was followed up for 6 months and eventually became asymptomatic. The creatinine returned to normal. And now currently requires only a single drug for BP control, and the complement levels also return to normal with normal urine. So what are the learning points that I wanted to convey here? One is to avoid polypharmacy and non-indicated drugs. Use those drugs only if they are absolutely indicated and for as long as you think they would be required, because every drug has a potential adverse effect which will be borne by the patient. Now, any new onset of hypertension in the background of an acute illness warrants investigation and close follow-up. It should not be left to the patient to follow up with you. Urine abnormalities need to be followed up closely and should not be left off again to the patient. And all of these cases would probably benefit from an early referral. In fact, at the point of 2.3 creatinine, that patient should have been referred. But thankfully here, no harm was done, so that's okay. The second case that I'd like to talk about is this 62-year-old female who was diagnosed as diabetic about 2 years ago and was treated with metformin. She was also on calcium and vitamin D supplements as she was postmenopausal. And this is something that she started herself. This is Google treatment. She knew that she's postmenopausal, so calcium and vitamin D supplements are going to be useful. So she started it. And there were no follow-ups on that, whether she needs to continue it and how long she needed to continue it. She presented with a history of chest discomfort and exertion for the last 1 month, which is on and off, and acute onset breathlessness for the last 1 hour. She was initially seen by her family physician. At that point, the ECG did not show any changes. So he gave some IV aminophylline, started on Lasix TDS, and sent her home. She said felt slightly better, so she sent her home. She returned 6 hours later with severe chest pain, sweating, and breathlessness. At this point, the physician referred her to a cardiologist, and a diagnosis of acute anti-reval MI was made. And it was also found that she has an ejection fraction of 35, and she has a dilated cardiomyopathy. Her creatinine at this point is already 1.5. She underwent an angiogram there, which showed diffuse coronary artery disease. So medical management was advised, and a mild anemia was noted. The patient was discharged by the cardiologist 5 days later. So this was the discharge advice. She was on Telma H, standard prescription, Telma H, Clopivas AP, Astor, metformin, PFOL, the usual. So most of her complaints were addressed with these medications. Now, the patient followed up with the family physician 4 weeks after this entire sequence, which she was feeling tired and she was complaining of easy fatigability and slightly decreased urine output for the last couple of days. And these were her initial reports. She had anemia 9.4, creatinine of 2.1, potassium 2.9, calcium is 11.5, and at this point, we are called. So again, we have a number of differential diagnoses here. Since we don't have a previous baseline other than the 1.5 to go on, we have to think of whether or not this is an AKI, an acute on CKD, or there was an element of already CKD, which is worsened, so acute on CKD. So that's what we would talk about here. So this would be the differentials, whether there is an acute cardiorenal syndrome, whether there's an element of contrast-associated AKI because the patient had undergone a CAG, pre-renal AKI, which Akash has covered so well, hypercalcemia has been noted, there is a presence of anemia, and whether there is a drug-related AKI. So do we have to also consider myeloma? So if we try and sort of talk about each of these, cardiorenal syndrome, we know is sort of the result of organ crosstalk between the heart and the kidney. Every time there is some degree of hypoperfusion because of a myocardial issue, the kidney suffers, and as a consequence of the kidney suffering, you have worsening anemia, metabolic abnormalities, and volume overload, and that is what causes it. The connectors between the two organs are your RAS activation and oxygen free radicals which are produced, and the inflammation that is triggered by all of those. So there are the classic classification is 5 types of cardiorenal syndrome. First 2 types are type 1, type 2, caused by an acute cardiac event affecting the kidney. Type 2 and 3 and 4 are an acute renal event affecting the heart, and type 5 is a systemic illness affecting both organs. So given this history, we would think that this lady is probably a type 1 or type 2 CRS because she has dilated cardiomyopathy, and then there is a renal involvement. There is considerable overlap between the 2 types, so it's not really necessary for us to try and narrow it down to one. It quite often you can have a type 2, type 4 overlap as well. So the second differential diagnosis would be a contrast-associated AKI. Now, this is now defined as an AKI that occurs 48 hours after exposure to a contrast agent. And contrast-associated AKI is one of the bugbears of nephrologists, and it's probably overdiagnosed a lot in our practice, because most of these patients are sick with other multiple comorbidities, and that is usually the cause. And the risk factor with IV contrast is a lot lesser than with intra-arterial contrast and in the setting of underlying cardiac illness, especially if there is cardiogenic shock. But that said, there is a very real risk of contrast-associated AKI, however small it is, and it should not be ignored. That risk should not be ignored. It's there most with those who already have a pre-existing CKD with a GFR of less than 30 usually, and those who have whatever some reason of renal hypoperfusion. Again, this could be sepsis, already underlying hypovolemia because of underlying illness, or cardiac dysfunction. So the one thing that I think, that's why I've not mentioned any of the other mucomics and stuff that we add. The only thing that really works is IV hydration. And if you are going to advise IV contrast to a patient, please make sure that they are hydrated adequately prior to and after the exposure to the contrast agent. This patient had hypercalcemia, and this is again something that I brought up here because a lot of patients are on calcium and vitamin D combination, partly because they think it's helpful for them, postmenopausal women especially. In this COVID time, pandemic time, a lot of people have ended up on vitamin D because it's supposed to be an immune booster with no monitoring whatsoever. So the hypercalcemia itself can cause acute kidney injury because it causes dehydration and has an effect on vascular tone, causing vasoconstriction of the renal parenchyma, and the combination of dehydration plus vasoconstriction causes AKI. The usual causes are primary hyperparathyroidism and cancer with or without bone involvement, but increasingly we are seeing off-prescription supplementation adding to the degree of burden that we see with hypercalcemia-associated AKI. Now, in addition to the hypercalcemia, this patient also had anemia, and that should trigger at least the thought process of the possibility of myeloma, especially given her age. So myeloma is known to cause AKI, and it causes AKI maximally by myeloma cast nephropathy, which is seen in advanced multiple myeloma, where the amount of free light chains sort of overwhelms the ability of the proximal tubule to metabolize it, and you end up forming casts in the lower tubules. It can also cause acute tubular necrosis and the iatrogenic effects of the drugs used to treat myeloma, especially when there is bone pain, or direct infiltration of the renal parenchyma, as well as acute tubular interstitial nephropathy. Now, all of these can cause AKI, and the way the patient responds to it depends. It's sort of an interaction between the amount of risk that the patient undergoes. So you can move from normal with some complications causing an increased risk to damage to kidney failure and death. The entire spectrum can happen because it's quite common to have kidney injury in myeloma, and about 50% will end up with chronic kidney disease. Now, the outcomes are also where a few patients end up in full recovery, but quite a lot progress to CKD, either from acute disease to acute on CKD, or directly catastrophic injury from which they do not recover, progressing to end-stage renal disease immediately after the AKI. So the learning points here are that in a type 2 diabetic, especially in the elderly, there is a predisposition to silent cardiac and renal illness. So it's important for us to keep that in mind and screen these patients early and prevent the onset of disease rather than wait for it to fully manifest and then deal with the fallout. Calcium and vitamin D supplements need to be followed up on and should not be prescribed without an end date in sight. The possibility of multiple myeloma should be considered in elderly AKI presenting with anemia. So Akash has already mentioned the sick day rule, so that has been sort of re-underlined here. And in any patient with multiple risk factors for kidney disease, we need to follow them up regularly. And like ma'am said, an episode of AKI in such patients may predispose to CKD, so they need to be followed up even thereafter, even after complete recovery. I think